Hello, I'm Kevin Quishan, and I am really excited to be here with you today and support the Hinman Dental Meeting. And our topic for today is health-centered dentistry, and specifically in the digital age. We have just about an hour here, so I really want to jump right into it. And I want to thank, you'll see a lot of help today that I have gained from a lot of people, including Sam Puri in the CERAC world, Narain Rajan in the 3Shape world, and John Cranham and Lee Culp, sort of overlapping a little bit. So I want to give them thanks as we get going here. I thought as we're talking in the digital world today, it'd be nice to break it down, almost simplify it. It's a very simple slide to simplify it. So we'll look at the digital world with respect to gathering the data, treatment planning, and then the actual treatment. And when we think about gathering the data in the digital world, more and more it's combining scanning the actual upper and lower arch, recording the jaw movements, maybe combining that with a CBCT. So we really have an individualized, fully functional articulator. Now we throw in the face and we can really see the function and the face and have a virtual articulator. And we'll talk a lot about that as far as data gathering goes. As far as treatment planning goes, what I get excited about all the time is some of us, most of us, honestly, if we're going to be honest, really don't like using wax. However, and treatment planning with wax, we leave that to the ceramists, and we all hated it in dental school. However, maybe if we could use our mouse to wax instead of actual wax, maybe we would be more involved in it and have more predictable outcomes. What does that setup look like? This is actually John Cranham's setup right now. You don't necessarily have to have 3 monitors, but you really start to think, as opposed to having a workbench with a Bunsen burner and a discoid cleoid and different waxes, it really is just sitting at a nice clean computer desk, having a workstation, using the thought process that we've been using for, basically since we were in dental school. And as far as treatment goes in the digital world, I know a lot of us are doing this, but it's going to be a review or an overview of how we can make things more predictable in the digital world with a couple of different scenarios. Those scenarios we're going to use today, we'll use Orson, who's 42 years old. We will talk a little bit about Jim, who is also in his late 40s at this point. And we'll talk about Josh, who is in his early 30s at this point. The only thing I feel like I want to make sure we get out front today is a disclaimer maybe, and just so everybody knows that, yes, I'm a dentist. I do have my own business, K-Squared Facilitation Dental Education. It's a coaching service, and I do some teaching at the Pankey Institute. So those are my biases that I feel like you need to know, and some other biases will come up, but I want to make sure I formally let you know and be very clear about those. So when we think about data gathering in the digital world, what are we looking to gather? What data do we need? And I think about just assessing the actual current system, the current chewing system with respect to joints, muscles, teeth, and periodontium, not just the teeth. And one of my biases that I just mentioned a minute ago is from way back in the 90s, the late 90s, the way I started looking at things that helped me stay more engaged and focused when gathering the data is knowing that I'm going to use these categories, aesthetics, function, structure, and biology, to actually treatment plan. So what data do I need for each of these categories that's going to help me systematically treatment plan? And we'll look at that in the digital world as well. Well, as we look at these 5 categories and we think about moving from the outside in, we always want to assess the joints. And how is the digital world going to help us in assessing the joints? Well, really what we want to start to use the digital world a little bit to help us identify is, what do we think is going on underneath the skin? What is our best guess as to how the joint is looking and where the disc is and how the disc is functioning, and start to think of it 3-dimensionally? Well, it is just a best guess. And really what we think about is, it is just a ball in a socket. It's the head of the condyle and the glenoid fossa with a disc that actually travels on the head of the condyle as we open and close. It is the only joint in the body that basically dislocates when you use it. The ball is meant to come out of the socket. So how do we assess that? What do we want to know? Well, one thing in the digital world that can help us is to get a better understanding of what's going on underneath the skin. It really is the sounds that we hear. And oftentimes the sound that we hear is just a little piece of the disc popping off and on, just a tiny piece. It's not so bad. And how big the pop is and where it pops has a lot to do with the forces that are being distributed as we open and close, moving from medial pole to lateral pole. Well, I would be remiss if I didn't bring up that this is the digital world, but it's been around for a while. To help us assess that, we can certainly use a Doppler to help get more information on where the sounds are coming from. And we can actually help the patient understand that a little bit more as well. As far as an understanding of the disc and the joint space and where it's breaking down, we can certainly use a joint vibration analysis, or JVA. And this also gives us a better understanding of what's going on underneath the skin. It's a best guess. And we have a report that tells us, do we think we have active breakdown going down, or a history of, and what part of the joint? So that helps us better understand what might be going on underneath the skin. And then we talk about loading the joint. And of course, today we don't have tons of time, but when we load the joint, we're shoving the ball up into the socket very intentionally. And if the disc is in the right place doing the job it's supposed to do, it should be what we call a negative load test. So one of the ways that we load the joint is basically by sliding on something that's keeping the back teeth apart. In this case, it would be like a leaf gauge. And when we slide forward and back and squeeze like we're trying to bite on back teeth, we are shoving the ball into the socket. Well, there's no real way to see that in the digital world, but things we can see to help us understand what might be going on really is a CBCT. And most people have a CBCT today, but are you using it intentionally for data gathering as opposed to only when we think we need it when bad things are happening? Well, how can we use the CBCT? Well, certainly we can basically look at it as a panel. We can take that data and use it as a panel and just start to look for symmetry of the head of the condyles, or the neck, or anything else in the mandible. So start to look at the actual anatomy, because if it's not symmetrical, the body's going to compensate or accommodate for that. And what about looking at each condyle? So if you look at the bottom right view, the axial view, we can start to see that her right joint is very different from her left joint. So anatomically, her body is going to be compensating or accommodating to try and make up for the asymmetry. The other thing we can look at is we can basically pan from the outside, basically by your ear, all the way into next to your brain, looking to see if you have cortical bone, that white that goes all the way through from the lateral pole all the way to the medial pole. Because if you don't see white there, that means there probably is some active breakdown going on. So we could look at that very intentionally. And then John Droder taught me many years ago to look for the loading zone, which is, again, if we take a CBCT in a fully seated condylar position, or even in centric relation with the ball intentionally seated in the socket, the place that should be closest as you scroll from lateral to medial would be on the medial side of the condyle, because that is where the pressure should be when you're biting together. And if not, you start to think, what is going on? Why is the loading zone closer to the lateral pole than the medial pole? Now, as far as evaluating muscles in the digital world, sadly, there is no great digital way to help us. That we do that with our hands, with pressure and talking to the patients. And we do still do that because we want to have an understanding of how is the body accommodating or compensating. Are the muscles being used too much on one side than the other side? Are the muscles bigger on one side than the other side? And why is that? But the digital world is not helping us too much there. But I'd be remiss if I didn't assess that part of the data gathering. Now, to start putting it all together, we can get better visualization in the digital world, and that is by using some type of a joint tracker or motion tracker or recorder, so that we can see how is the jaw moving. Does it deviate to the left or to the right when we open? What happens when we move to one side? And that's when we get to start combining all of the data and really have this individualized, fully adjustable articulator at our disposal. As we continue to look at the way the teeth function. How can we see how the teeth are touching when they come together and how they're touching when we move side to side? Are the front teeth actually protecting the back teeth, or are the back teeth getting in the way? And maybe is that why some teeth are breaking or getting cracks or wear facets? So again, historically, we have our patient, grind to one side as far as you can and grind to the other side as far as you can and grind forward, at least till the edges touch. And then we put some articulating paper in there. And we could maybe use red when we go side to side and front and back, and green when we tap, so that we can see, are the front teeth protecting the back teeth, and are the back teeth touching evenly and simultaneously? And that can be confusing to us, even those of us who are quite proficient at looking at the tape and understanding the noise in the tape, et cetera. Well, something that's also been around for a long time, of course, I get no money from them, or, I get nothing from promoting. I just think it's helpful for us, especially the way things are changing these days as we start combining our scans and our CBCTs and now the T-scan. You can really start to see what teeth are bumping when we move side to side, and is it on the inclined plane, and where are all the teeth touching? Or is it cusp tip to flat landing area? Are they touching evenly and simultaneously? So we assess the body. We're using some of this digital, some digital concepts and armamentarium, if you will, to help us gather the data. But we also want to see, how much is the body having to accommodate? In other words, when we bite together, as you see here, to get into maximum intercuspation, or your acquired bite, how much is the ball having to come out of the socket? How much is your lateral pterygoid muscle having to pull the ball out of the socket? In other words, how much is your body accommodating or compensating? Said in a not so nice way, how much is your patient's body in disharmony? Well, we're all in some disharmony. We're human beings. But I want to find out how much our patients' bodies are compensating or accommodating, because when we're in disharmony, bad things can happen. If the front teeth are not protecting the back teeth, and the back teeth are touching when we move side to side, so many things can happen. Fremitus, mobility, bone loss, tooth fracture, abfractions. So how do we see just how much our patients are compensating or accommodating? Well, really, it's just a bite record. It is a bite record in a fully seated condylar position. So in the analog world, what we do is, of course, we can use, in this case, it's a leaf gauge. So we slide forward, back, and squeeze, take some leaves out, slide forward, back, and squeeze like we're trying to bite on back teeth, all at the same time deprogramming the lateral pterygoid and using the muscles to shove the ball up into the socket. Until one time, when we take enough leaves out and we slide forward, back, and squeeze, all of a sudden the patient feels a tooth that is touching. That is the tooth that touches with the ball in the socket. That is, you might call it centric relation or a fully seated condylar position. But now we can see how much the body is having to accommodate to shift to get all of the teeth to touch into maximum intercuspation. Well, now we sort of combine what you see on the right here. You are seeing the shift from centric relation or a fully seated condylar position into maximum intercuspation or your acquired bite. Well, I think this is good information. It's helping us understand why the teeth are breaking, why the patient is having headaches, why we're having some joint issues, why we're having fremitus, mobility, cracks, et cetera. So basically what we're doing is taking a bite record, open, anywhere from 2 to 3 or 4 millimeters, depending on if you're using a leaf gauge or some type of a Lucia jig. Close the pin and you're going to see the tooth that touches with the ball in the socket. Well, in the digital world, the question was way back in the day, when I first got into this, can you do this in the digital world? And the answer, even back then, when it wasn't so common, was absolutely. So what you see here is models mounted in the position with the tooth touching or the teeth touching with the ball in the socket. And it happens to be the second molars, as you see here. Well, how did I actually get that bite record? Well, it's everything we just talked about with just a little twist in the digital world. So I've already scanned the upper and lower arch, and now I leaf the patient down to where he feels the first point of contact. and then take the bite record on both sides. And I thought to myself, what if he shifts forward when I'm moving the scanner from left to right? And then it's not going to be as accurate as the analog world. So can it be more stable and more predictable? And the answer is yes. Why can't we go back to the analog world, put a little silicone in to help him stabilize and keep that first point of contact where it belongs, but cut the buccal surface out, the premolar area out, where we're going to scan the bite. So I do go back to the analog world for stability, for predictability. And in the 3Shape world, this is one of my good friends, Narain Rajan, up in New Jersey. So his patient has a piece of silicone in right now. And you can actually, she could stay there all day long. And Narain he's already scanned the upper and lower arch. He's now scanned her bite in centric relation on one side. He's got tons of time, all the time he needs to move to the other side while he's scanning the bite on the other side. And he now has an upper and lower model mounted on a virtual articulator in a fully seated condylar position. So certainly we do this all the time, and it's getting easier and easier today. So again, what you see on the right here are teeth mounted on a virtual articulator with the ball in the socket. And on the left, you are seeing the slide from centric relation into maximum intercuspation. You will actually see the slide. That's how much the body is accommodating to get into maximum intercuspation or your acquired bite. So in the digital world, these are the things that are helping us assess the current status. Now, the way I think about it is that I want to share with you today is there's really only three things that impact what we just saw and that are going to impact the predictability of the dentistry that we do. And one is sleep or airway, the other is nutrition, and the third is wellness. How are you dealing with stress in life? Well, the only one that's really going to be helpful in the digital world would be airway or sleep. Now, we all know that this scan, no matter how tiny the air hole is, it is not indicative or diagnostic of anybody that has any airway resistance or sleep disorders. But it certainly is a great screening tool and encourages patient awareness and engagement quite a bit. So I do love using a CBCT just as a screening tool, but it certainly is not diagnostic, but it can be quite helpful. Also, since we're taking CBCTs, why can't we look at why the patient is actually breathing through their mouth? Why are they an obligatory mouth breather? Well, we find here on accident that this patient has a deviated septum, cannot be breathing through her nose on a regular basis. And this might be contributing to why the patient is posturing forward or is an obligatory mouth breather and is destroying her teeth. As we get concerned or worried about how airway might be impacting our teeth, the digital world is helping us quite a bit here as well. Certainly something we can recommend to continue to evaluate our patients that's completely free is SnoreLab, right? We probably all have a cell phone, we all do, and that can bring some awareness, or the Aura Ring that I happen to be wearing right now, or a high-res pulse ox, or even a home sleep test. I have for years been using the Metabite Lite and Metabite Junior, which really helps me assess. Again, this is not diagnostic because I have a DMD after my name, not an MD after my name, but it certainly is a good screening tool and it helps me engage the patient to move forward. So that really is the data gathering in the digital world. Now, as we move forward into treatment planning, what are we actually treatment planning? Well, when I think about treatment planning, I think about treatment planning what is optimal. In other words, what's it going to take to restore our patient back to optimal health? And for me, when I think about restoring, so when we all got out of dental school, we were so confused. We didn't have a way to systematically treatment plan, and our brains went everywhere. And a lot of us are still that way. And my hope for everybody, for all of you listening to this right now, is pick a pathway that makes sense. I happen to, at Pankey right now, we teach global diagnosis. So I'm always, quoting Bill Robbins and thanking him, starting from the face and the outside in. But a systematic approach that makes sense is what I hope for all of us. And that's what I'm going to share with you today so that it's the same every time. And how do we use that in the digital world? So when we think about what optimal is, optimal would be that when we bite together, that the muscles work together on the left and the right to pull the ball back up in the socket where it belongs. And as the muscles pull the lower jaw up to the top jaw, and the ball is in the socket where it belongs, in a perfect world, we would also have all of the back teeth touching evenly and simultaneously, cusp tip to flat landing area on the top and the bottom. So a cusp tip on a tooth and a flat landing area on a tooth, cusp tip to flat landing area. And when we move our jaw in any direction, our front teeth make the back teeth come apart, but in a very smooth, shallow manner so that they protect the back teeth. So when I'm thinking about treatment planning that, I want to treat for optimal. And I do that in a very systematic approach. And we always start with aesthetics. Now, we've always called it aesthetics, function, structure, biology, and airway. For me, it's not about aesthetics. And that's what I want. It's going to be very helpful in the digital era for all of us. It's not so much about aesthetics. It really is, the E for me is more about edge position. In other words, always starting with an idea as to what is it going to take to get the front teeth in the right place in the head to do the job that they are supposed to do. By default, they might look good, so you can call it aesthetics. But for me, my starting place is always, how can I get the front teeth in the right place in the head to do the job they are supposed to do, which is to protect the back teeth? And no matter who our patient is, that is always my starting place. No matter what they walk in for, that is always my starting place. So that for somebody that seems complex like Orson, how do we get to this vision of where we want the front 12 teeth to be, the top 6 and the bottom 6? Because it can seem a little overwhelming. Well, no, again, I'm going to walk you through this, and we're going to look at the analog world and then also the digital world. So at 42 years old, how much tooth should be showing for a male at 42 years old? Well, how about at least a couple of millimeters? Well, we have to know how far up under his upper lip the tooth was to start with, so that we know how much to add to show 2 millimeters or 2.5 millimeters. You can call it 3 millimeters if you want. But we're all going to be within a millimeter of each other, I promise you. And the studies suggest that over and over again. So once we know where we want the incisal edge position with lip at rest, now our next photo that we use is our smile photo. And if we do add that 2.5 or so millimeters, this photo is our check and balance. After we add those couple of millimeters, now the incisal edges should be cradling the lower lip, sort of, pretty close to that. That's how we know they're in the right place in the head to do the job they're supposed to do. And now we can outline the existing teeth. We can draw, we can use DSD, as we'll talk about in a minute, a lot of different ways, but we want to get all of the distractions out of the way. So put it on a black background. And this is what's really critical right now. Once we know where we want the incisal edge, we put the incisal edge there first. Notice the difference. Those were the couple of millimeters we were going to add. Once we know where we want the incisal edge, now and only now do we measure up from the incisal edge to get proper height to width ratio. And now we can compare. We get to see the difference between where our patient is and where we want to go. It doesn't mean we know how we're going to do it yet. It's just to get a clear vision of what optimal looks like for us. So we do that on the top 6 teeth, and we do that on the bottom 6 teeth. Now we have a vision of where we want the front 12 teeth to go in the head to do the job that they are supposed to do. Now, you can pretty it up if you want on the right. Back in the day, I was using Pixelmator. You can use DSD. You can draw. There's a lot of different ways. I don't care how you want to do it, or if you're doing it for you or for the patient. For me, it is a treatment. It is for treatment planning. I need to see where I want the front 12 teeth in the head to do the job they're supposed to do. So now when you think about the digital world, if you were to have scanned the upper and lower arch and then had a bite record in a fully seated condylar position, Now, if we knew what we were going to do in the analog world, you can start to see what we're going to do in the digital world, which is put the edges where you want them in the head. Always start with the front teeth. Whether you're in the Sirona world or the 3Shape world or the ExoCAD world, we always start at the same place. Put the front top 6 teeth where they belong, and then the bottom 6 teeth where they belong. To throw an example in as to why we follow the scenario, that I just showed you, if all we did was say, let's give this patient beautiful height to width ratio, and we would all agree that those teeth are probably going to look pretty good. And even if we had models, whether it's in the digital world or the analog world, we would say, oh, yes, that's a great treatment plan. Let's wax that up. And that's going to be our treatment plan. And that will be the treatment that we do. Except what we forgot to look at was where his teeth were in his face in the first place. Where are the incisal edges? When you look at his lip at rest, when you look at his smile, when you watch him talk, those edges are already in the right place. He's basically had wear and secondary eruption. So we now start to think, oh, in the digital world, how can we do that with what we would have done in the analog world, which is start to use our photos, right? And get similar data points. So eyes, nose, teeth, incisal edges of teeth, and start to combine those data points. And now we know where we want the incisal edge. In fact, we like where the incisal edge. I like it, don't you? So let's now use all this data to come up with where we want the incisal edge, then find the proper height to width ratio so that we have a vision of what optimal is for his top 6 teeth. And then again, we would do the same on the bottom 6 teeth. What we used to do, starting with aesthetics, and a lot of you still do it, and I still do it, and you can even use printed models. So on printed models, you can still go back to old school wax. It sticks, it works, been doing it for years. However, how long does it take you to even wax up? I'm pretty fast at it. I promise you, I can't do what you see on that printed model in 12 minutes, but I can do it in 12 minutes with a mouse. If I'm doing it with intention, because I know where I want to actually put those incisal edges and how I want those teeth to look. So I can treatment plan virtually using photos and start to get my digital wax up much quicker than I can in the analog world. But if you don't know what you were going to do in the analog world, the digital world probably isn't going to help you so much, is it? So, and we'll talk about this in a little bit, but of course, if you have this blueprint of what you want the teeth to look like, you can print a model, you can have a mock-up, and if it's mostly additive, you can actually view the mock-up in the patient's mouth. Again, a lot of you do this, and we've been doing it for years, but start to think about your flow and doing it with intention. I think it's going to be helpful, because once we know where we want the front 12 teeth to be in the head, now we get to function. And when I talk about function, I mean, are the teeth moving, protecting the back teeth in a smooth, shallow manner? So if we go back to Josh's models in the analog world, if we put the front 6 teeth on the top where they belong and the front 6 teeth on the bottom where they belong, and then we go cuspid rise, even beyond cuspid rise to cross over to one side, cuspid rise, beyond cuspid rise, cross over to the other side and end to end, they should be protecting the back teeth. And to help you sort of play cooking class ahead of time and see what it's going to look like when it comes out of the oven, we're going to also do the back teeth. But if you don't know what you were going to do in the analog world, the digital world isn't going to help you so much. Because I want us to have the same idea that I just showed you on the analog models in the digital world on a virtual articulator. It's not just doing a pretty wax up, it's starting with function. And in the end, I want to have a blueprint. And so now you're thinking, well, can we trust that, Kevin? Well, we can certainly trust it. We have always had articulators. We have in all the software, we've had virtual articulators for probably since 2010 now. But nobody was using them back in 2011, 12, 13 until we started looking at them a little bit differently. The downfall, of course, was how do we put the top teeth in space where they belong? How do we have something that's like a face bow in the digital world that we use in the analog world to put the top teeth in the proper place and space so that we can trust our virtual articulators? And the answer was sort of, maybe yes, maybe no. Because even back in the day, you could always program the articulator. It was a fully functional articulator. It wasn't a semi-adjustable, it was a fully adjustable articulator. And in fact, we could use it with the CBCT, which we have. Imagine if you had a CBCT and you could actually measure the distance between the condyles. So as opposed to having it be an average on a semi-adjustable articulator, you could literally measure it and make it a better articulator in the virtual world. And think about things like condylar inclination. And we've struggled to put that on our semi-adjustable articulators, but in the digital world, if we've actually recorded jaw movements and have a CBCT, you actually can measure the exact angle of the eminence, which is basically the angle of disclusion in the posterior determinant in the fossa. Well, that's pretty awesome. However, it was taking a lot of work, wasn't it? But it was there for us. And so we've had a lot of renditions of a digital Facebook using data points, trying to use photos with data points and grabbing and scanning the upper and lower arch. And there's been some that have come a long way. This is one of my friends in Poland, he really was inventing this on his own with some engineers. But I guess it is sort of rocket science. It's not easy. Some of you are familiar with the French company Moja, who is, as far as I can see right now, are collaborating again in a very intentional way with DSD to try and really digitize this. So Moja is making a nice comeback. I'm a big fan of John Coyce. Now we start to see that if we use our photos intentionally, and they've come up with these glasses so that if you scan the upper and lower arch and use the data points with the same photo, you can use these glasses to make sure that the top teeth are in the right place and space for a virtual articulator. Or for those of us who really see the benefit of the digital world and the analog world, what if you had a face bow that was easy to use, just an ear bow, and you can use the Nasion, but as opposed to the bite fork with the bite tabs or silicone bite registration, you're just going to put a little silicone in the incisal edge position. And imagine now that you've already scanned the upper and lower arch, complete upper and lower arch. And now the patient has this easy to put in ear bow, and you see the data points on the underside of this. And so now you're connecting the data points on the underside of this more analog face bow, but it's very easy to use. And now you basically have the digital information of where that upper arch fits in space for your virtual articulator. So you want to talk about things moving in the right direction so we can really trust our virtual articulators and moving into the digital world. So, and even if you don't do that, these days, if we have photos and we've scanned the upper and lower arch, you are in a virtual articulator, you can literally just combine the data and you really do have the top teeth in the right place in space, don't you? So the Facebook is becoming less of an issue as long as we know why we were using it and which technique we're going to use. So now that we know that we can trust these records, now you can literally take a centric relation bite record. And again, got to go back to the analog world of using a leaf gauge. So slide forward, back, and squeeze. So he is holding that position. And in the digital world, as we just said, you can leaf him down to the first point of contact and then just cut out some of the buccal area there for the scan. So now you actually have scanned his lower arch and his upper arch. And when you go to take the bite record with those buccal areas carved out, you now have his models mounted on a virtual articulator in the right place and space in a fully seated condylar position. So let's go into the aesthetics part of it. How does that look in the analog world and how do we apply that in the digital world? Well, for me, it always starts with the front teeth. I've sort of already beat that into you and we're only, 33 minutes in here. You're starting to get the idea that it all starts with the front teeth, putting those in the right place in the head. So you've got this vision of where they go. And in the analog world, if you had models and you're overwhelmed or you're not quite sure where to start, I will urge you to always start in the same place, no matter what the patient walks in for, which is use your photos because you know where you want the incisal edge and put the edges where they belong. And this is actually my wax up, and it's okay to, you can tell me how ugly it is, but I'm proud of the systematic process, putting the centrals where they belong, moving to the laterals, and then moving out to the cuspids. Put the edges of the front 6 teeth where they belong. And now move down to the bottom, whether you need to grind them away, recontour them, add, it doesn't matter. It doesn't mean that's how you're going to do it. It means you're creating a blueprint of what you want it to be, and then you're going to decide how to do it. So you've got the bottom 6 teeth where they belong. And this really also represents your vertical dimension of occlusion. If you've got the front 6 teeth where they belong on the top, and with the linguals that look like linguals, and sometimes we have to think about that, and then the incisal edges on the bottom where they belong, and close the articulator, that is your vertical dimension of occlusion. And now we just have to check and make sure, are the guiders guiding in a smooth, shallow manner? So we go cuspid rise to crossover, cuspid rise to crossover, and end to end. And sometimes it's not totally smooth. And you think to yourself, well, I've got the teeth in the right place in the head. Why is it still not smooth? Well, probably because back teeth are still getting in the way. So simultaneously, you can be getting the back teeth out of the way, at least the bouncing interferences, while you're making sure that the front teeth are doing the job they're supposed to do in protecting the back teeth. So let's go back to Josh for a minute and bring this into the digital world. So in the analog world, we start always where? With the front teeth, putting the edges where they belong based on the photo that you see on the bottom left. Well, whether you're chairside or CERAC InLab or 3Shape or exocad, what is the first thing you're going to do? You're going to put that incisal edge where you want it. You can measure free gingival margin to incisal edge, or you can measure the amount of wax that you wanted to add. Is it 2 millimeters, 1.5 millimeters, etc.? Now you're going to go down to the bottom teeth. How much did you want to add or remove? If it's add, go ahead and add it. So in the digital world, what would you do? You would wax that, except you're going to wax it with your mouth, with your mouse. And then you are going to close the articulator, close the pin. And what does this represent for you? Right? It represents your vertical dimension of occlusion. In fact, in this chairside version, it actually says, if this is your new 0, you are going to lose all the restorations, which is why I only did the top 2 and the bottom 2, because now I have my vertical and I said, yes, this is my new 0 point. And I actually now know that I have opened his vertical exactly 1.7 millimeters. We used to always guess this, or we weren't sure, but now we know exactly how much we're opening it up. And now you can come back and finish what we started. Let's finish the front 6 teeth on the top and the front 6 teeth on the bottom. And that now represents your vertical dimension of occlusion. And now you want to make sure that they are guiding nice and smooth. So whether you're in the 3Shape world, the Sirona world, the exocad world, it's always the same starting place, isn't it? The digital world can really help us do things that we didn't like to do previously. But now if we understand what we would have done in the analog world, it's going to make the digital world a lot easier. So we want to put the edges where they belong. How quick can you wax this as opposed to going back and forth with your heated waxing instrument and carving it? But if you don't understand what you were going to do in the analog world, I don't think this is going to help you very much. So we've got the top 6 and bottom 6. And you can see the difference. If we liked where number 9 was, and you can still see some of the model poking out at number 9. If we liked where that incisal edge was, we bring number 8 to that, and then number 7, and then we're going to add to number 6 and make it look like a cuspid. And once you have that, now your virtual articulator that you can trust, you can make sure that the front teeth are guiding and protecting the back teeth. And you can start to see, are the back teeth in the way? And if the back teeth are in the way, you're going to at least start to get rid of the balancing interferences. So yes, we start with the face, and it is the incisal edge position, and it does impact aesthetics, but it's really Where do the teeth belong in the head to do the job they're supposed to do? And as we said earlier, a way to sort of test that if you're in the digital world, and how one of the many ways we use printers these days is to go ahead and print out a model of your digital mock-up. So we haven't even taken an impression yet, but we do have to go back to the analog world of making a putty. And again, if it's mostly additive, you can try it in. How are her aesthetics? How are her phonetics? And she can even slide side to side and see how the front teeth are guiding. Are they protecting the back teeth? You're going to see exactly what you would have seen on the articulator. So once we've got front teeth doing the job they're supposed to do, what about the back teeth and how does that look in the digital world? So again, we've got the front teeth guiding in a smooth, shallow manner. Now all we have to do, it's really the easy part, which is keep the ball in the socket, leave the condyle closed on the articulator, tap, tap up and down, and we have to get all the back teeth touching evenly and simultaneously. Well, one of my mentors, Margie Mannering, years and years ago said, as opposed to winging it and hoping you get back teeth to touch, why don't we start by taking a look at what's already close to touching? What cusp tips are already close to touching a flat landing area, a fossa, a marginal ridge? What is almost in the right spot? Or what needs to be slightly moved, mesial or distal or buccal or lingual, so that as we start to look at that, we make some notes and how quickly can we put cusp tips in flat landing areas where we want, even on the most difficult of cases like Orson's. And in the end, this was my wax up. I have all the front teeth doing the job they're supposed to do, and all the back teeth are touching evenly and simultaneously, cusp tip to flat landing area. You see, in the digital world now, you're starting to think, I know where I'm going to start. I'm going to make sure I put the front teeth where they belong, the edges are where they belong, and then I can start adding back teeth and getting cusp tips and flat landing areas. And now it's not just a crazy wax up that's random. We've done it very systematically. And whether you're using, again, CEREC InLab or chairside or 3Shape, the end result is all going to be the same because we looked at it very systematically. And now and only now do you get to decide what structure is appropriate. Whether it's my ugly models or the digital models, you get to come up with a treatment plan for each tooth. What's it going to take to make each one of his current teeth look like the teeth on your digital wax up or your analog wax up? And I'd be remiss if I didn't say this is when I think I would propose to all of us, I would urge all of us, this is when you sit down with your specialist and say, I've got this blueprint of what optimal is. Let's figure out how many different ways we can help the patient get there, because there are always so many different ways. And once we know the structure we want, now and only now do you get to biology. Now that you know what each tooth, what the restoration is and how you want it to look, you say to yourself, do I have the biology? Do I need a root canal first? Do I need crown lengthening? Do I have enough bone there? Can I move the tooth there? Do I have the biology to do that? And then finally, this is when you sit down with your specialist and say, can we move the teeth there? Do we have enough bone? Can we do crown lengthening there? Can we graft there? And so we go aesthetics, function, structure, biology, and then always these days airway, because if airway has not been considered, then it's going to have a negative impact on the predictability of everything above it. So now we actually have a digital blueprint of what optimal looks like, but we've done it in a very systematic way. We know what it looks like to restore this patient back towards optimal, and the digital world helped us do it quite efficiently. And now I always like to throw this in there because we do know that form follows function. We can actually have conversations with our patient. We can be worried for them and concerned for them and talk about how we can move from your current condition into one that's going to be more maintainable and healthy for you long term. The digital world helps us print these out as well. We can have a blueprint of what optimal is and use it in so many different ways so that we can now get to treatment. Now, when it comes to treatment, for me, what I think about is what is appropriate treatment. Now that we've assessed the current status, we know what's impacted the system. We have a vision of what optimal is. We've had a conversation with our patient. What is the appropriate step? And I'd be remiss if today I didn't say one appropriate step that I need to bring up in the digital world is maybe it's appliance therapy. Maybe it's proving to ourselves we can create comfort before we actually start messing with teeth. And yes, the digital world helps with that also. We've been designing appliances digitally for predictability for a long time now, and we're even printing them now. You literally can see all the back teeth touching evenly and simultaneously with the front teeth protecting them in a smooth, shallow manner. And we've been printing these for a long time, haven't we? And how's the predictability of that? I would say pretty great. All the back teeth touching evenly and simultaneously with the ball in the socket, and the front teeth discluding them in a smooth, shallow manner. You can mill them out of a big piece of acrylic if you want for like an anterior bite plane. You can scan the upper 6 teeth in and do a crazy design. And now you've got something that's protecting the front teeth. You literally can make it somewhat directive, can't you? What if I wanted to use these temporarily while I've got temporary veneers in to protect the teeth, but it's also an airway issue and I want to direct the mandible forward? I can mill this out in a heartbeat. One of my friends and current coaching clients in Michigan is printing these out for an anterior bite plane, basically to go home and finish diagnosing or to use as a deprogrammer. So literally printing these out. So you can mill them or you can print them out. So many things you can do in the digital world now that we struggled with back in the analog era. So as we finish up with appropriate current steps, trying to bring it all together in just an hour or so for you today. One of my favorite things is the fact that we can scan at every step of the way. And we've been doing that for years. Trios a while ago called it the patient monitoring, but we'd been doing it even before they called it that, which is if you know what you want your teeth to look like, you could scan your provisionals in. So you literally you can have your pre-op scan and know where your treatment plan was and look at your provisional scan and see that, yes, you actually added those 2 millimeters on the incisal edge. What's even cooler than that, of course, you can ahead of time make sure that you have enough space for your restorative material, that you prepped enough for the restorative material. And now you know already what you want because you've treatment planned it digitally, you already know what you want your restorations to look like. So this becomes quite quick and easy. And to make sure that we are staying consistent, you always could, but you can scan if you want to print out a printed model. You can scan your final restorations on a model so that you can actually not be surprised to see that a lateral has been milled a little bit longer than the provisional. So you knew what you started with. You got to see your provisionals and make sure that the changes were accurate. Now you have your final restorations and you can scan those, and they should be pretty darn similar all the way through, so that there's no surprise. We knew that lateral on number 7 was going to be a smidge long. And in fact, thought we'd try it first and it looked pretty good. So what I want you to see here is that, and when we talk about the software, what I've shown you a lot today is the CEREC in-lab, but I've also shown you 3Shape. But to do these, and then exocad also, it really is to do all of this. It is the lab software. CEREC in-lab, 3Shape, or exocad has all of this that you see here. But it is there for you, and you can use it and buy it as a dentist. And I think that's going to help you along the way. I think we're all going to be using it sooner than later, but it is there for you. And so start to think that way. So let's go back to Jim for a minute, and then we'll finish up with just these couple of cases. Jim had been missing his front tooth since he was a teenager. It was a hockey accident. And how did the digital world help us? Well, I mean, obviously, we've all been doing this. Think about treatment planning. Did we have enough bone there? Where was that implant going to be placed? Could we trust the placement? Well, if we knew where we wanted the incisal edge to be in the first place and had a vision of what optimal looked like, it helped us treatment plan that. And in the digital world, once that implant was in place, literally we could scan with a scan body and quickly design, and I mean quickly design, a crown. But for this particular case, I didn't really want a crown in there. I designed the crown and then lowered it, cut it down so that I could have a custom healing abutment using enamic. So that on the same day, I now have a custom healing abutment that was predictable because I knew where the implant was going to go to support the tissue. And even on the same day, the digital world helped me so much because I could quickly design a little Maryland bridge to at least give him a tooth there while the custom healing abutment was below that. And I designed it, and it was quite predictable because I could quickly design that. And in the end, if we know where we want those incisal edges to be, where do we want the front teeth, so that we place the implant there and get the healing abutment doing the job it's supposed to do, while he's actually healing up, we can actually design a crown because we know what we want it to look like. And we know how the tissue is going to be about when he comes back. So when he comes back in and I take out the healing abutment, this provisional crown is already milled and ready to go. And in fact, it was milled weeks before. Why not? And we can certainly make it a screw retain provisional as opposed to a cement retain provisional now. And I knew what it was going to look like, so there were no surprises. And I could sculpt the tissue just a little bit more because my custom healing abutment did a great job, but I could push it out just a little bit more. So I made myself a note as to where I wanted to add some composite. Long story short, he hadn't been brushing his teeth because he was so afraid when he was wearing that bridge in his provisional, which I can take some of the credit for that, not making him feel confident. So on the day we put this in, I thought, well, for now, let's make him look all the same. And it was very predictable. And then after we cleaned his teeth and he realized he could start touching things, he could come in and I had another one ready to go. And the tissue was looking great. And again, I thought I'd sculpt the tissue just a little bit more. But how predictable is this? And on the top right-hand corner there, you see that the digital world really helped us make every step of the way completely predictable. From left, where you're thinking, how could this ever work after all this, to the right, where every step of the way went great and there were no surprises. And in fact, on the day this is just a try-in photo, just trying in the veneers, because that's what was appropriate for him, was these steps, moving him towards health in a way that was appropriate for him. So when we get back to Orson for appropriate current steps, where did we start? Putting the front teeth where they belong in the head. And then having a vision of what optimal look like. And of course, one of my specialists that I sit down with, as I mentioned to you earlier, is my ceramist. And this was Matt Roberts up in Idaho. And because I had a vision of what optimal looked like for Orson, and I knew Orson couldn't afford it, Matt said, well, Kevin, we've got these big blocks of acrylic and I've got this 5-axis milling machine. Now, this was back in the day. Because we were doing this back then, and people like Matt were so smart, this is happening all the time now. The digital world is helping us, where we can basically do these overlays. And that is the way it would look. But because we knew potentially it wasn't going to look great, we could also mill out some really, really thin overlays. And in fact, on day one, what was appropriate for Orson was I went back to the analog world, because my restorative material of choice for his lower incisors was composite. But I knew where I wanted the incisal edges. So I put the incisal edges where I wanted them because I knew that's where they needed to be for the front teeth to protect the back teeth. And then bonded in, or luted in, I should say, well, sort of bonded, luted with flowable composite, the rest of those onlays out of acrylic that we printed out. So he now goes cuspidized to crossover, cuspidized to crossover, and end to end. That's not a bad day's work right there. The front teeth are doing the job they're supposed to do, and the back teeth are mostly touching, mostly even simultaneously. It's not perfect, but it was the appropriate first step that we could have never done without the digital world. Going from the top 3 photos to the bottom 3 photos in one day is not a bad starting place. And I took a scan of this so you could see that basically he's got a lot of back teeth touching, and his front teeth are mostly protecting his back teeth, which allowed us then for him to come in many, many months later and prep just his upper six teeth now. Like, why don't we finish putting the guiders in the right place? And his provisionals for that day, because I knew where I wanted them, there should be no surprise at how much tooth was showing with lip at rest. And I actually just milled those provisionals out. Why not? I had a clear matrix ready to go, a putty matrix ready to go, and a, um, a digital template of where we wanted to go. So I thought, why not just do that and click mill and go up and do nothing for a while? So that's what I did. And you want to talk about an easy bite record as well. So he bites together with that proper vertical that we set, with the back teeth touching with the ball in the socket. That's not a bad bite record. This makes everything we do much easier. So basically, that was a scan of his provisionals now that Matt could use to help create his permanent restorations and compare the provisionals to our first treatment plan to what looks good now. And there's no surprise, of course, that we changed it just a little bit because my provisionals are never awesome. Matt knows exactly where we want the incisal edges, does cutbacks, but only on the facial, so that now Orson comes in and we go cuspidized to crossover as far as we can go, cuspidized to crossover as far as you can go, and end to end. That's not a bad stopping place for a day. And then he can come back in anytime and do any of the top teeth. And in fact, the cool thing is he came back in and did all of the top teeth, the rest of them. It wasn't easy for either of us. It's not the way, I'm not always so good at it. But what you see here, you want to talk about an easy bite record. He bites together with just the front teeth touching where they belong. That is his vertical dimension of occlusion. And it also seats the condyle just like a leaf gauge would. So not a bad way to come in and make some provisionals. And then he can come in and just put the top teeth in. Now the bottom teeth are still in those onlays, so it's not perfect yet, but the top teeth are designed with the cusp tips and flat landing areas where we designed them way back in the day, just waiting for the bottom teeth to be done. So this is not a bad holding pattern for a while. It's what's appropriate for Orson. And then he can come in the next year. And the next year we prepped just the bottom right. And the digital world helps us so much because we didn't want to do both sides. It was a lot that day for both of us. So we thought, let's just do the bottom right. But all I did was just scan those for the final impressions, final scan, and put provisionals on for the better part of a year. And then he came back in and I prepped the other side and then just had to take the provisionals off on the first side and connect the scans so that basically I could have done these one tooth at a time and kept connecting the scans at one side at a time and connecting the scans. But in the end, you wouldn't know if I did these one tooth at a time or did the whole lower arch at one time. The digital world helps us so much. And now I've got those top teeth ready to go. And it's so easy to design, to finish the design of the bottom teeth. We already know where we wanted the cusp tips and flat landing areas. Why? Because we planned them, both in the analog world or now if you were doing it just in the digital world, you knew why you were doing it. So as opposed to just having a wax up, I am designing where I want my cusp tips and flat landing areas because I also know where I want front teeth to do the job they're supposed to do. And in the end, as I put the bottom teeth in, and this was just basically no adjustments, you already start to see a lot of cusp tips and flat landing areas with the front teeth still there doing the job they're supposed to do. And if you watch really closely, with just a couple of adjustments, I've got the plan. And how did I know it was going to work out? Because we designed it. We designed it digitally. But if you don't know what you were going to do in the analog world, the digital world is not going to help you. But if you do know, then the digital world all of a sudden is going to help you do dentistry that maybe you weren't doing back in the day because it was a pain in your butt in the analog world. And so what was appropriate for Orson, now he's got cuspidized to crossover, end to end. It took a while and it might not be perfect, but it's what I would say is appropriate for Orson at that point in his life. And the digital world and the systematic approach helped me do that in a way that made it easy for both of us. Now, he could be wearing an appliance right now, or he could be wearing a mandibular advancement appliance to help him breathe, or nothing. my point here is that this flow helped me help Orson move towards optimal health in a way that it was appropriate for him. As we finish up here at exactly an hour, as I look over to my clock, you cannot, one of the things I deal with every day with teams, with dentists and teams across the country is how do we incorporate this into your practice? How do we integrate it? And you all know this, you can't do it without your team. But my hope is, and what I preach is we do it really more revolving around the team. We really create team-centered systems based on what optimal looks like for you and your practice. And when we all know what optimal looks like for us in our practice, and we develop our systems around our team, what experience do you think the patient has? The patient has a great experience. But if we move away, and I know this scares you, but I have to bring it up anytime I present. If we can move away from a patient-centered practice, and I know we love them, but towards a team-centered practice, what does optimal look like for us? Your patient will have a great experience, and the digital world is going to help us even more than that. And so at exactly 1 hour and 41 seconds, I don't know exactly how I did that, but I want to thank you for allowing me to maybe be a positive influence for you, helping you think about things a little bit differently, giving you more competence and confidence for you and your team. So thank you for giving me the opportunity. I'm thankful to be a part of Hinman this year. I'm excited to be there, and I hope to see you there as well. So again, I hope this was helpful for you, and thank you for giving me your time. Enjoy.